Nice to see you, Papadis Athanasios, and we will present a case. It's a STEMI in a post-TAVR patient, and I will talk a little bit very fast about the significance of commissural alignment. So the case is about a male, 71 years old, that presents to our ER with a typical STEMI, anterior STEMI. I have to say that this patient was a TAVR patient 8 months ago, and it was actually special that he had a valve-in-valve case because he was operated in 2016 with trifecta number 23 with severe aortic regurgitation. From the cardiovascular risk factors, arterial hypertension, dyslipidemia, and normal kidney function. So as we see here, we can appreciate actually that before the TAVI, there was absence of significant coronary artery disease. So despite the abnormal RCA, we don't see anything significant here. The valve-in-valve was made successfully. I have to say that here we were measured everything. It was a little bit below 8.2 millimeters. I marked that to see, but we let enough distance from the coronaries to be sure that this patient will be actually also a candidate if it needs in future for a coronarization. So we respect the coronary takeoff with a CT. The TAVI procedure went also really good. Actually, here we can appreciate the deployment of the valve. It was actually nicely made, and the result was also very good with low gradients and almost any paravalvular leakage. So the ECG was like that when he left the TAVI, and 8 months later, when he came with a STEMI, was like that. The pump function of the left ventricle was also decreased. What we saw here is actually we had a mid-LAD almost obstruction and diagonal 2 significant lesion. The catheterization followed actually with a JL 3.5. As we know, when we have a valve, we need to take smaller catheters. Here is actually the diagnostics, and I will go then actually farther here to see also that the lesion is here in the LAD, clearly visible. It's in the middle of the LAD and almost an obstruction. And then we will see it here also. This looks like a thrombi. I'm not sure if it is a thrombi really. Anyways, we used then an EBU 3.5. We were from the left radial artery, as I said, and the wire was actually nicely advanced till the distal part of the vessel. And it was actually an angioplasty was followed with direct stenting of 2.512, and then we saw actually that we had problem with the flow in the diagonal 2, the TIMI flow 0 fast almost, we don't see it here. And in addition to that, the patient became unstable. We had the ventricular fibrillation, and we had to give a defibrillator. He was stabilized later on as we passed the pilot 50 to the diagonal, and we followed with a balloon dilatation. And it was actually ended with proximal optimal a pod actually with a non-compliant balloon in the LAD region before the diagonal, with a very good result, I would say, for the acuteness of the case. The patient was actually in the ICU, very stable, under tirofiban. A few days later, he left the hospital with ejection fraction 50 and a good mean gradient in the prosthesis, aortic prosthesis, 15 mmHg. So actually what we saw here, the incidence of the STEMI in the post-TAVI is very low, but the clinical outcomes are very bad. We clearly see that it happens more to patients that receive a self-expandable valve. We said here that the patient received also Medtronic balloons to us, and it was also very nice to say that most of the patients that have that complication is a valve-in-valve, so everything passes really well. The incidence is 0.2 to 0.3. If it happens in the first 7 days, it's really bad, and if it happens later, it's also bad, but not that bad. The stent implantation successful rate is actually also not so high, but 70%. In this occasion, we have a late obstruction of the vessel of the coronaries, as we saw here, and is mostly in the self-expandable valves. Here there are some predictors. I won't go in everything in detail. We are in this category. As you see here, it's also written that there is a thrombus and the fibrosis or the stent endothelialization or the late expansion of the prothesis. So we are in this category. We are in the late, and I believe we had a thrombus here. And the most probable, as it says, is the valve-in-valve as the etiology of that, what happened. So a little bit about what we see. If you see that the patient actually left our catheterization lab and our hospital after the TAVI with aspirin and clopidogrel, so we have to say that that happened actually under DAPT. And the previous guidelines, they were saying about 3 to 6 months for DAPT when there is a high risk, but the newer guideline says about SAPT with aspirin. So this patient was actually happily in the clopidogrel and aspirin therapy, but it didn't help him so much. Both American and European. Here we have to say that the challenge of cannulation in valve-in-valve patients, it's very obvious and known, and it has to do with the new skirt that is created from the two protheses and majorly from the commissural misalignment. But this has to do also, especially in this patient, this case, because it was a surgical valve, and we have to trust our friends, surgeons, that they actually respected the alignment because they see the osteo of the coronaries, something that we don't do, interventional cardiologists. So we go to the biggest new theme that's also in Europe now, very, very much discussed actually about the significance of the commissural alignment. There are many studies that they are running, and they have also already proven that the durability of the new valve depends on the alignment, because it has to do also with hemodynamics of the coronaries. The leaflet stress is less, so the valve is getting old actually less quick. So we have a better result. So in this case also, we were lucky enough to do a good alignment, commissural alignment, which actually is defined as a less than 30% deviation between the native and the NOI commissures. The new commissures are the commissures of the TAVI, and the native, of course, the older ones. So when we do the CT preparation for these patients, we really need to have an unidentified commissural overlap view. We need to have the view that we will put the C-arm and be sure actually that we will do an overlap of the new commissures to the older ones, to the native ones. There is no methods to facilitate commissural alignment actually in the current generation of balloon expandable TAVIs. So we only talk about the self-expandable valves on these steps. There is a very nice paper from Alexander Wolf, actually from Essen in Germany, that he did a very nice review, and he explains very nicely here how we do the isolation of the cusp overlap view, because the first step is actually to identify the native commissures. So this is done in the CT, and when we actually go on this side, we actually have isolated the intercoronary commissure, and be sure that here we have the non-coronary cusp. So the next step is actually to identify the new commissures in our prothesis, and here comes that every company has its own mechanism, own marks. So here it gives also the paradigm of accurate new and the navitor, that they have the commissural post, so it's much easier and visible for us to see where the new commissures of the valve are. So if we are really in the cusp overloop view, we could really appreciate where we will put the new valves according to the commissural post that we see here. About the Medtronic uses the C marks. The Evolut has 2 C marks. Here the thing is to isolate again the non-commissural cusp, and then we have actually the intracoronary commissure, where we actually use the C mark, which is perpendicular to the hat. The hat is very nicely placed here, and we actually place the valve so that we know that the hat is 90% and directed to the intercoronary commissures. So if the hat in the cusp overloop view looks on us and we have it really in the front, we will be sure that actually the C arm is between the intracoronary commissure and have a good overlap alignment of the coronaries. So the tips, I'm ending with the last slide, is the left radial or the transfemoral approach for the coronary access. Use smaller catheters, as I said. Then there is also that over the wire the guider that we actually take the guider in the aorta. We have the wire inside, and if it's needed to do a PCI, we will also use a catheter extension for that to help us and have more stability to do the PCI. So that was.
Well, thank you, Thanos. Petros, any comments?
Yes, excellent demonstration how to cannulate coronary after a Medtronic valve, because a lot of people are afraid of it. Just a question, why did you start with a diagnostic left catheter and you didn't go up front with a guide catheter, because you knew that it was an acute MI?
That's a very good question. Actually, I think we did it to be aware actually of the anatomy, and if we could use an EBU, because EBU doesn't always be so guidable when we don't know if we can access the coronaries. So we could actually take a JL, for example, and start with Sideholzer to start the guide directly, but we did first the diagnostics. I don't know why it was.
Okay, I accept that, but there is always a trick. There is no need to cannulate the ostium of the coronary with your guide cut. Just go nearby, put a wire, put an extension catheter, and you're done. So there's no need to worry about cannulation, selective cannulation or not.
Absolutely, absolutely. I agree. This is actually what I said in the last slide, that if you are next to the coronaries, you just go in front, and either you take the extensor or you go just directly with the wire, and then you can manage it.
Good. So thank you, Thano. This was a very nice demonstration of, if you place a self-expanding valve, you don't actually lose access to the coronaries. You can always do your coronary angiogram or your PCI as long as you place the valve in a good position.
Thank you very much.
Okay, so thank you.